Over the last couple of weeks, we honestly have not been doing very well in the pressure injury department. This last week, we had 6 new injuries on the B side. Actually, we got rid of one, so 5, and 2 on the A side. That's a lot more than normal for us. So what I'd like to do right now is share the results of the case reviews that I did from this week. I'd like to really thank everybody for helping me do these case reviews. So I reached out to all the individuals that were taking care of the patient and asked for their input, and we got a lot of very useful information. So the first case is a gentleman who had had a transplant, a liver kidney transplant a couple weeks ago, and was with an open abdomen, very unstable, was do not turn for a number of days, and developed a pretty significant DTI. On flip day, we turned this patient and they identified the ulcer as a stage 2 pressure injury. So as it turns out, this is actually the evolving DTI. So it was not a new injury at all. So the night nurse noticed that during the shift this area had opened up, and when she turned the patient with the day shift nurse, that change of shift, they discussed it and they put a wound consult in, and so that's really excellent. What wasn't so excellent is that this wound is documented in 4 different places, and therefore it appeared like a new injury this week. Furthermore, the documentation really didn't have any details of the wound, and it just said DTI, so we really have opportunity there. Next, we have a patient that was received overnight as a rapid response. The patient had deteriorated on the floor, ended up intubated, and it came to us quite unstable. Our issue is that we did not notice the pressure injury on arrival to the unit. So I honestly don't see much opportunity other than to be very, very careful, because these are the kind of patients that inevitably will have some breakdown. They were struggling on the floor for a number of hours before they deteriorated. So be very, very suspicious that this kind of patient is going to have a pressure injury on arrival. So immediately we have been using barrier cream, and we got a wound consult, and luckily this area is resolving as we speak. So I found that 6 out of the 8 pressure injuries were device related, and honestly I think that this is where our opportunity lies. Some of you might remember, and although I know a lot of people are new, that our unit-based team project for SICUB was to reduce the number of device-related pressure injuries in the unit. And we actually got very, very good, going for really weeks on end without getting any kind of pressure injuries from any devices. So we need to regroup immediately. Remember, any of these devices can cause pressure injury. So collars, bedpans, ET tubes, and the tube holders are notorious. Face mask, BiPAP mask, fecal incontinent devices, nasal cannula, pulse ox probes, A-lines, flotrons, splints, braces, Foley catheters, the wristband, the blood pressure cuff, oxygen tubing, any kind of cast or trach ties, the trach phalange, and of course ECMO cannula. It's pretty obvious why these devices are hard plastic. They're hard to secure. It's hard to see under them. Sometimes there's bad positioning, or the device is not fixated right. The size of our patient actually fluctuates due to edema. Our patients have every comorbidity in the book, and most of them have really very, very bad perfusion. But honestly, I'm going to suggest to you that in the following cases, if we had paid extra attention and checked our tubings and the devices, we could have prevented these injuries. So first, let's look at a mucosal injury due to an NG tube. The nurse noticed it, and immediately they removed the NG tube and placed a Dobhoff tube. The Dobhoff is secured with the appropriate device and is floating to prevent further injury, and a wound consult was immediately placed. It doesn't really take much to get a mucosal injury in your nose, because the soft tissue is so vulnerable there. These injuries are very, very painful to the patient, and can really leave really very, very bad scars and the necessity for cosmetic surgery. So I want you to take a look now at the second NG tube that we place now in the right nair, And you can see that in a very short period of time, we're going to have exactly the same problem because the angle of this tube is such that it's pressing on the outside of this gentleman's nose. It really needs to be free floating and not exerting pressure on the outside. So my suggestion is that if we had paid attention and not let the NG tube pull against the nose in the first place, this injury possibly would be prevented. Here we have another example. Number 1 injury there is the inside of the lady's nose. Number 2 is a potential injury due to the ET tube holder being too tight. You see it's puckering her face. And number 3 is on the upper lip. The NG tube and the Dobhoff are taped very well. They're in very good position now. And the endotracheal tube holder has been moved up. Obviously, it had slid down on her lip. And the only way that we're going to be able to prevent these injuries is if we're paying attention and insisting on repositioning the tubes. I know you can imagine how uncomfortable or painful these injuries can be for our patients, and they can cause deformities that require plastic surgery. The only way that they have a chance of not getting these injuries if we're paying very, very, very close attention and being very proactive to make sure that it doesn't happen. Okay, this injury is clearly from a pulse oximetry probe. The nurse noticed the injury and passed it on to the oncoming nurse, but it was not documented until flip day. There was a wound consult placed actually, but again, very obvious. When you have a pulse oximetry probe on the ear, it usually means that somebody has bad perfusion. Please rotate the sites, take them down, look under the probe to make sure that you're not getting one of these. I think we'll actually say that our practice is to take it off every shift and to rotate the site. So the next pressure injury was found under the lower phalange of the trach, and that's a very common injury. The sutures are often in too long. So here the nurse actually had requested to remove the sutures, but didn't get anybody to help, and then a few days later the injury was developed. So I'm going to say that sometimes the physicians don't see this as a priority, and we have to see it as a priority. If you try to get the sutures out and nobody bites, then please escalate it, and we will go speak to them. The rule of thumb is that sutures can come out in 7 to 10 days after the trach. The last 2 pressure injuries were heels, so 2 heels. Again, we noticed the DTI and did have the patient's feet up on pillows, but unfortunately the pillows smush and the heels end up on the bed. I think that the effort was there, but we just have to make sure that they really are free floating and that there is air between the heel and the mattress. And funny thing how patients move around, so you just have to continually check every time you're in the room that you still have your heels floating off the mattress. This patient actually had perfusion that was so bad that 3 different injuries occurred in the span of 1 shift. So after reviewing all of the cases, it's clear that our opportunity lies in device-related breakdown. And again, if we were able to eliminate it before, we can surely do it again. So I'm asking everybody, help each other. If you see an NG tube that's pulling, if you see a tube that's dragging on the mouth, or an ET tube holder that is too tight, just speak up and get something done about it. You almost have to have eyes in the back of your head. In saying that, I really would like to say that I was pretty pleased and really proud of the team. We caught the injuries right away. The documentation was there. It could have been a little bit more detailed to be sure. Truly didn't miss anything. Really what we're asking is to kick it up a notch and refocus on these devices and get us back to the standard that we expect in the SICU. And I guess, as well, I really do appreciate, we all appreciate that the assignments have been very, very busy. The acuity and the census have been insane for weeks, if not months. We've got a lot of new staff, a lot of agency staff, and it's not easy. But I know and I am confident that if we all work together, that we can really get back to our baseline.